Now we have the distinct pleasure of welcoming up Dr. Sharon Nachman. She is the SUNY Distinguished Professor and has held multiple leadership roles at Stony Brook across the Division of Pediatrics, Infectious Diseases, but also in research across the Renaissance School of Medicine and the Office of Clinical Trials. She is also a Stony Brook graduate, having done her MD here at the university. So this is truly a great day today, having two of our amazing graduates now be two of our amazing success stories. Her talk today is titled HIV Then and Now, and she'll provide a same sort of style talk and questions after. Dr. Carolyn Milana, the chair of the Department of Pediatrics and physician chief of Stony Brook Children's Hospital, is here to say a few words about Sharon, but before she does, I do just want to say a few words about her. She's board certified in pediatric hospital medicine, specializing in the medical care of hospitalized children from birth through the age of 21. She completed her residency at Stony Brook University Hospital and has been the chair of pediatrics since 2018. What's really interesting and amazing about her work is that it extends beyond bedside care. She's an avid contributor to the pediatric field of medicine, focusing on quality improvement. She's published several successful publications and enhanced outcomes and services, ensuring that children receive the best possible care. She's a leader dedicated to shaping the future of pediatric healthcare for the community. And when you have someone who has been a leader, who has been a great scholar, a clinician, and someone who has shown such great care for the health of children, it is really a great privilege for us to have her here. So with that, I will bring Carolyn up and see the folks.
Thank you, and good afternoon. I have to say, I've known Sharon for many, many years, but I really can't go back to the beginning because I have no idea where you were born. So we're going to keep that a secret. But I have known Sharon for a long time, and it really is my great pleasure to introduce her as my longtime friend and my colleague. You know, she was one of my attendings when I was a resident here, so we go back a very long way. As you mentioned, Dr. Nachman received her MD from Stony Brook Medicine and then went on to complete her residency at our competition over at Snyder Children's Hospital. She did her pediatric infectious disease fellowship at New York Medical College and then went on to do some additional training as a physician scientist at Rockefeller University. Dr. Nachman has led an exemplary and distinguished career with a long history of service, both to our institution as well as to the national and international communities. She currently serves as the Associate Dean for Research and as the Division Chief of Pediatric Infectious Diseases at Stony Brook Medicine. Additionally, she's a SUNY Distinguished Professor. She sits on the World Health Organization Technical Advisory Group on development of guidance on best practices of clinical trials, and she chairs the International Maternal Pediatric Adolescent AIDS Clinical Trials Network. Her awards, grants, and publications, honestly, are too numerous to list because I could go on forever. Although Dr. Nachman's recent claim to fame has been through her work with COVID-19, I'm sure many of you during the pandemic turned on the TV and there was Sharon on the news explaining what was going on with vaccines and clinical trials and promoting getting vaccinated and sort of keeping the calm across Suffolk County and truthfully across the tri-state area. The reality is she has spent the majority of her career working on another global crisis, the HIV epidemic. There are countless numbers of people who have been impacted by her tireless efforts and the research and treatments she has provided for this disease, and it really is my pleasure to have her come and welcome her.
Thank you very much, Carolyn. So, as I tell people, growing up in HIV, how I got here, I'm going to talk a little bit about that today. family and work dynamics. I always get asked by the students, so where was your work-life balance? And I tell them every day I tap dance and making the most out of every opportunity. I have no conflict of interest. What that means is that my family is still waiting for me to get money from pharmaceutical companies. I know they're still waiting. My funding goes through 3 different institutes, NIAID, NICHD, and NIMH. So I thought I'd give you a little bit of history. In 1981, there was an unexplained cases of enlarged lymph nodes among gay men, and these were in New York, and I read those articles and I went, this is never gonna be a problem for me. I don't see adults, I don't see gay men, I'm out Long Island, it's not so much of an issue. There was the first report of 5 cases of homosexual men who had pneumocystis carinii pneumonia. And that's a pathogen that we only find in severely immune-compromised patients. And that MMWR happened in June 5th of 1981, and that's exactly when I graduated from my 6-year BSMD program, and I'm like, it's not gonna be a problem for me. I'm going into pediatrics, you know, I'm never gonna really see this. In 1982, there was additional cases around the world reported, and then some disease reported in hemophiliacs, and perhaps a few women, infants, and recipients of blood transfusions. And again, I'm like, it's hematology's problem, not my problem. It's not gonna be an issue for me at all. At the Pasteur Institute, 2 different physicians isolated a new retrovirus from a patient who had these AIDS or immune deficiency syndromes, and they called it lymphadenopathy-associated virus. And then our colleague Jim Oleski in New Jersey, see it's getting closer to us, he's a pediatric ID doc, and he published the first case in May 6th of 1983 of a groundbreaking paper describing a pediatric case with HIV. And that's exactly when I started my internship. And I went, oh no, this is going to be my problem too. Moving through the eras in 1983, the CDC warned of blood banks saying, there may be a problem. Now, I don't know what you think about medicine, but we never want the CDC to say there may be a problem. That's always a bad news kind of a thing. 1984, Dr. Gallo from the US National Cancer Institute, or NCI, reported that his lab isolated a virus, and he called it human T-cell lymphotropic virus. So what do you think? These 2 viruses were exactly the same virus, and it was worldwide. And it took a little jostling between the 2 science groups to say, I got it first, no, I got it first. But we, in the clinical world, said, we don't care who got it first, it's here. And in 1985, the federal government licensed an HIV antibody test, and they started screening the US blood supply. I was a resident at that time, and we were seeing children die. And we had no idea why those children were dying, because this test really wasn't going to be particularly accurate in children, and you couldn't get it. You couldn't order the test, it was not available, you had to send blood away, and the kids were dying. And this is a picture of Ryan White. Ryan White was a lovely young man. He was a hemophiliac, and both of his brothers were also hemophiliacs. And they acquired HIV from blood transfusions because that was standard of care. You were hemophiliac, you got lots of blood. And they were chased from their community and had to leave because people in their community wanted them to leave. They wanted to kill them, they wanted to burn their house down. And that set the stage for how people thought about HIV. Oh, you got it, you're excommunicated, I shouldn't talk to you, I don't want to see you, I don't want to see you on a bus, I don't want to see you talking to me, I can't share my pen with you, you can't sit in the same restaurant as me. And so this is sort of a little bit of a chart as to, by year, how many cases of HIV we had, or AIDS. AIDS is AIDS defining, meaning your end stage, and how many deaths. And you can just see the numbers year by year going through the roof. By 1991, there were 1 million Americans that were infected. And at that point, some personalities started saying, oh, guess what? I have HIV too. Magic Johnson reported that he had HIV. Freddie Mercury from Queen died at that time. And there was the red ribbon that symbolized if you had HIV or were talking about HIV or going to see patients with HIV. So if you looked at any of the movies at that time, you saw people wearing red ribbons. So what did I do? Well, I wanted to do pediatric infectious disease, and I decided that I would go to a program that allowed me to see everything. I really wasn't going to travel out of New York, and Just for Carolyn, I'm a New Yorker born and bred, born in New York, went to school in New York, elementary school, high school, college, med school, residency, fellowship. I wasn't leaving New York. So I decided I needed to go to an ID program that allowed me to see not only domestic medicine, but international medicine. I went to Lincoln Hospital in the South Bronx, part of New York Medical College, and every day I was excited. Malaria came in, you know, we saw kids with various and sundry other diseases. I saw lots of tuberculosis. We had an entire ward of kids with measles. So I used to go home every day and say, guess what I saw? And you know, my family would go, that's really nice. After that, I did my physician scientist training program at Rockefeller. That was a totally new environment. It was lab-based. It was new challenges and new opportunities to understand how does the other half think. When you're in clinical medicine, you get a lab value, you act on the lab value. After all, there's a patient behind that lab value. On basic science research, you get a result in the lab, and the first thing you do is, I have to repeat it 4 times with 15 different controls because it can't be right. And learning how to think the other way really helped me progress in my career because I could act on what I saw and then 2 steps back and say, did I really see what I saw and do I really believe it? The take-home message is to step out of your comfort zone and learn to think about how does the other person think. Now it was time to get a job. I had to look for a job, and I was, of course, not afraid to promote myself and look for my dream job. And interestingly enough, nobody was interested in me. So, you know, I thought I was doing a great job, and the only place that offered me a job was actually Stony Brook. What was really interesting is at that time, there was an acting department chair who hired me, Dr. Leonard Kleinman. And then I was, okay, fine, I'm going to start in the summertime. There was a new chair of pediatrics who was hired in the time from when I interviewed to when I would start. His name was Richard Fine, and I showed up a couple of days after he showed up, and he looked at me and go, who are you, and what are you going to be doing here? I said, oh, don't worry, I got this. You don't have a division of pediatric infectious disease. I'll build one. Of course, somewhat naive, seeing I had just finished my fellowship. I had no contacts with anybody. And I said, not only am I going to build a division, I'm going to build a fellowship program, and I'm going to start a research program. And he was like, all right, honey, do whatever you want. Let me know how that works. So the first 2 years that I was here, I wrote my first grant. That got funded right away, which was kind of exciting. I didn't know that you just write stuff, you submit it to the government, they go, oh, sure, here's money. That's very nice. But soon thereafter that first grant, the group that decided how to take care of HIV had their first clinical trial. It was called 076. And 076 was a study that said, can we prevent pregnant women who have HIV from transmitting infection to their children? At that point, 25% at least of all pregnant women with HIV were likely to transmit their infection. And at that time, HIV was a lethal infection. So if you transmitted infection from mother to child, that was a death sentence for that child, and more likely than not, they would be dead by a year, maybe a year or 2. Occasionally someone lived longer, but it was a horrible life. So that idea that we could stop transmission from mother to baby was an absolutely out-of-the-box, how in the world could you possibly think of it? My colleague Ed Connor, who was the PI, principal investigator of that study, was like, after he finished the study, and I'll show you some of the results, left clinical medicine because he said, I could never do anything that made such a difference. So what did we do with that study? In that study, we randomized women to get AZT versus placebo. AZT was a drug that was on the shelf by GlaxoSmithKline. They had looked at it, it was worthless, it didn't do anything most of the viruses, nobody wanted it, and they kind of shelved it. Ed Connor and his group came up with this idea, why don't we try this antiviral on HIV? And surprisingly enough, for those of you who have never worked with a pharma company, the pharma company said, sure, you want it? Here, go ahead, we'll give it to you for free, have a good time. And their lawyers didn't put up a fight. Until that point, anytime you wanted to do a clinical trial in pregnant women, the first thing the lawyer said was, no, you can't do that. So it was an incredible surprise to all of us clinical researchers that the pharma company would give us the drug for free and said, you can do whatever you want with it. I was a young investigator here at Stony Brook. I had a grant that would allow us to enroll pregnant women on that study, and I was pregnant at the same time. And the most important question I got asked by every single one of these HIV-infected mothers, would you take that drug also? And the answer was, at that point, yes, because if I can prevent even one transmission, I was going to be a success. And here you could see the chart of the numbers of HIV-infected women in the US and how many new babies we were having. And that red line on it, that red arrow, shows you when 076 started. And you can see from that chart what happened. The numbers of new infections plummeted because the study worked. And what did we do? That 076 study showed a 68% reduction in transmission from mother to baby. So we went from having 25% of all women transmitting HIV to less than 8% of all women transmitting HIV. Nowadays, we talk about looking at CD4s and viral loads. We had none of those tools at that time. We just had, you're infected or you're not infected. So the fact that we were able to do this study across the country, and more importantly, we were able to do it at Stony Brook, was incredible. And I remember the Data Safety Monitoring Board broke the code on a Friday and made us unblind all the women. So I came back on Friday to Stony Brook, and I started to have to find all the women that we enrolled on the study. And because not all of them had phones, we couldn't find them, I had to involve Suffolk County Police Department to go to homes, knock on doors, and say, Dr. Nachman wants you to come to the hospital now, and escort them in so I could take their placebo meds and give them true antiretrovirals. So this pediatric clinical trial network all of a sudden had a life of its own. We could do something that we could never do beforehand. What was important? We were young whippersnappers. A group of us sat in the back of the room and, I want to be polite here, heckled the professors in the front because we knew they had no idea what they were talking about because nobody knew. As a result, they went to this and pointed me in the back and say, you think you know so much? Why don't you come up to the podium and you can decide? Okay, I'll take that challenge. And soon thereafter, I wrote my first clinical trial that involved protease inhibitors from 3 different pharma companies in an attempt to treat HIV-infected children. And every pharma company said, you want our drug? What are you going to do with it? I said, just give it to me. I got this covered. I'm going to write a study. And we wrote a multiple rolling arm master protocol so that as soon as an arm finished with a new antiretroviral, we opened another arm and enrolled another 200 children, opened another arm and enrolled another 200. And that data allowed us to get protease inhibitors, which were a new class of antiretrovirals licensed for children around the world. The important take-home message is, just keep pushing the envelope. If you don't push, you won't get anywhere. So how do you describe this new illness? Well, you have to write illness categories. And again, being the guys in the back of the room, we knew that we were not talking the same language around the world. We would say, oh, do you see this? Our colleagues in sub-Saharan Africa going, no, we don't see that. Do you see this? So a group of us got together by the CDC, and we all had to sit in a room with the doors locked until we could come up with a common language. Because once you have a common language to describe a disease, you could then treat it, because you could all measure the same outcomes. So what did we do after that? The drugs were not licensed. We had no liquid formulations. We had no pharmacokinetic data. We didn't understand anything about drug-drug interactions. We didn't know what to do with opportunistic infections. Well, that sounds like a big burden to the audience. It was very exciting to me because it meant that I could think of a plan. I could use that training I had from Rockefeller and say, I don't know. What's the right experiment? True, these experiments were on patients and on pathogens in the lab, but the yield of it was so much greater because it meant I could save lives in an absolute direct way. So you had to learn how to be a triple threat. You had to learn how to do the scholarship, write the papers. We started that study in protease inhibitors in the late 1990s, and in 2000, when we had a nice paper for JAMA, which is a top-tier journal, I got to be able to present the data at one of our large international meetings, introduced by David Ho, who was the maven on HIV at that time. I learned to work with the system, move up in the system, while I was doing stuff here at Stony Brook with teaching awards, talking to HouseF. But I thought I'd spend just a little minute and talk about what else I had done at that time. One of the important things that I would do, just like all of my colleagues, is go to national meetings. And when you're at national meetings, the first thing you do is you put your glasses on and you read posters. Everyone presents a poster, and in those days, it sounds like a long time ago, we didn't have cell phones and took pictures. We wrote stuff and got copies of those abstracts and posters, and I collected them and I read them in my off hours, sometimes in the evenings or daytimes, just to keep a sense of what was going on. So here we were at Stony Brook, and we had a little 9-month-old girl admitted to our pediatric ICU. She was a former NICU baby at 27 weeks gestation born, and she had a very complex necrotizing enterocolitis. Her GI tract did not work. And as a result, it was disconnected, and she had ostomies and stuff, and her parents were very involved in her care and took care of her, and she was living at home, and she was doing okay. And about 9 months of life, she got incredibly sick. And what did she get sick with? She got sick with a resistant pathogen that was resistant to all of our known antibiotics at that time. And she was intubated and doing poorly in our pediatric ICU. The father was an anesthesiologist, the mother was a teacher. They knew this baby was gonna die. I was the pediatric ID doc in the place. And I said, I read an abstract once about a new drug which had no name. I'm gonna figure out something to do over here. So I got the poster, it had a name, I looked up the person's name and their phone number from the pharma company. It was Pharmacy in Upjohn, they don't exist anymore. And I called them and I said, hi, it's Sharon. And who are you? And why are you bothering us? I said, I have this lovely 9-month-old baby who's going to die. I need some of your drug. Here's the call numbers of the drug, MK1234. Can you send me some? They were like, we can't do that. We have to call the FDA. All right, so call them. I'll wait on the phone. You can call them. So they got the FDA on the phone. And the FDA was, again, who are you? And what do you want? And I said, here's my plan. I want the company to ship me the drug. I'm going to figure out a dose. I'll do a back-of-the-envelope calculation based on how much the kid weighs and the dose you gave to an adult, and I'll put a fudge factor in here. And I said, and we're going to give this drug, because if we don't, this baby will die. And the FDA said, well, if you can write a clinical trial and get compassionate use approval from your institution's IRB, we'll approve you to give the drug. And the pharmacy guys said, if they said it's okay, we'll ship you drug. So I sat down on a Wednesday, wrote what I wanted, sent it to the IRB approved it, they sent it to the FDA approved it, they shipped me drug on Friday, it came to our institution on Saturday. Remember, this is an experiment. And we went, the pharmacy got here in little brown glass bottles with no name, just call numbers on it. We made up a solution and we hung it. And within a day, the baby completely recovered. And I wrote everything that happened hour by hour sitting at the bedside, who's doing what dose, what we're giving, what are the labs. I made an entire lab notebook. And I sent it back to Pharmacy in Upjohn. And I thought, all right, I'm done. The kid survived, we're all good, everybody's fine. So Pharmacy in Upjohn took that information and they said, maybe we should actually develop a clinical trial plan for pediatrics. After all, if this kid needed it, some other kid might need it. They didn't connect back with me or anything. They had my entire lab book. Everything was sent to them. And I went along my merry way. A couple of years later, I got a call from Pfizer. Pfizer bought Pharmacia, and they said, your name is all over the paperwork for this drug. Why? You're not part of the pharma company. So I told them the whole story. They were like, okay, fine, that was very nice. Lo and behold, a few years later, I got asked to go to Congress to testify. The same exact dog and pony show. I went to Congress, I went with a family, we testified, we talked about the drug and stuff like that. All right. A couple years after that, I got a call from the Pharmaceutical Manufacturers of America. We'd like you to come and get an award. And I'm like, why? They said, well, you were the first person that ever made us change our plan. You were the first person that changed completely how we were going to do a licensure pathway for a drug in a group we never considered. It changed what we're going to do. It changed everything. And they pursued licensure for that drug in pediatrics. Since we don't have a standing award for clinical researchers like you, we're going to make one up. And you will be the first person to get that award. So here I was, and I went with the family, and I got my award from Clinical Trials Excellence. And since then, they've continued to give this award to other clinical researchers since then. And I guess the take-home message is, don't be afraid to push the envelope a little bit. So don't think that you have to restrict yourself to one specific area. In academic medicine, we're always taught, oh, you should pick your area of specialization and stick with it. And I never liked that information. I always thought, well, if I can think about a lot of different questions. So over the years, I decided there's no pathogen I shouldn't be interested in. And I did clinical trials in every single one of these vaccines. And as you can see, the study number is next to it. The population is next to it. And those studies changed licensure of those vaccines in those populations. You have to start at the bottom. You have to think, how are you going to move up in the ranks? And also continue to be on service. And while I was on service, I was also thinking and teaching, what else am I going to do? And because I complained so much, don't listen to that, Carolyn. Because I complained so much, I got stuck with doing new jobs. I complained about the promotions and tenure here at Stony Brook way back years ago. And the dean at that time said, I'm tired of you complaining. You're now the chair of that committee. I'm like, I've never served on that committee. Well, you complained about it. Now you fix it. Okay, fine. Clinical trials office, the same thing. I complained about we needed a centralized office with processes and SOPs, and I complained about it, so I had to develop it. So I thought I'd spend the last little bit talking about HIV, since after all, that's where most of my grant money comes through. New HIV diagnoses disproportionately affect adolescents and young adults. People that are aged 13 to 34 account for more than half of the new infections now in the US. And HIV infections continue to occur in children despite the fact that we know that we can give those mothers antiretrovirals and give them. And in fact, in 2022, there were 130,000 new HIV infections worldwide. And despite good antiretroviral coverage in pregnant women, 1.3 million women with HIV are going to become pregnant each year, and that's going to have a big downstream effect. Because if you only cover 80% of them with antiretrovirals, you're still going to have significantly new infections. So why invest in pediatric research? Why should anyone think about spending money on what I do? Well, the investment return for investors in young children greatly outweighs the return for any adult population. For every dime you invest in children, you're going to get a bigger return than if you invested the same dime in an adult. And prenatal and postnatal health sets a lifelong trajectory for health. So if you fix it early, you will have benefit for the rest of their lives. Only 10% of ongoing registered clinical trials include children. And 70% of these are in high-income countries. So when you think about it, we're not getting clinical trials in children, and we're not doing them in low and middle-income countries. So there's a need for specific research in children, adolescent, pregnant, and postpartum people. What are the issues that we have to deal with on a daily basis? We'll have to think in the HIV world about viral host interactions. There's immunologic changes that happen. Maternal pregnancy infection is also different. And then I don't have to tell you as a pediatrician, there's physiologic changes across the ages. There's anatomic changes, there's developing brain, and for those of you who have children at home, you know that the developing brain of an adolescent is unlike anything anyone else has ever seen. And that translates to me in the HIV world, that I have to have different treatments for young children, different treatments for adolescents, different treatments for pregnant and postpartum individuals, because I really have to think about where the virus is, what's the immune response, and where are the reservoirs for that virus if I'm going to get to eradicate HIV. So I'm going to move now to my Impact Network. The Impact Network is the maternal child HIV network that I chair. And I have been doing this for the past 10 years. I am the one who's wrote the RFA for this, responded, have a network. And our mission is to improve health outcomes for infants, children, adolescents, and pregnant and postpartum people who are impacted or living with HIV. We have a very, very robust group of individuals who work. And as you can see, this looks like a business model because in fact it is a business model. It's one thing to say we're doing clinical research. It's another thing to say where taxpayer dollars are contributing to how we do clinical research. And you have to be able to blend the science with the business in order to have a successful network. And this is our table of organization. We have specific scientific aims. We are focusing on treatment during pregnancy and postpartum, as well as potent and durable antiretrovirals for children across the ages. We want to be able to get to ART-free remission or antiretroviral-free remission. We want to cure HIV. We want to evaluate how to prevent TB, diagnose TB, and treat TB, because the pandemics of HIV and TB kind of hit at the same time. And we also have to remember that the brain is part of HIV, and we have to determine optimal and feasible treatments for brains and mental health. So we have these across several different scientific committees, including a therapeutic group, a cure group, a TB group, and a brain and mental health group. Our current portfolio is quite robust. And if you look at this in any detail, you will see that there's a whole lot of drugs on here that are not licensed for children. Why is that important? Because in fact, it is our network that gets these drugs licensed for children. This is a snapshot of us by the numbers over the last decade since I've been running the network. We had 37 studies. We had almost 12,000 participants. 82% were Black and African. 57% were children. Remember that WHO slide? 10% of the studies were children. We are way ahead. 57% of our studies include children. We've had over 300 publications. We have 52 sites around the world in 12 different countries. So when I think about stuff that's happening here at Stony Brook, it's happening around the world. And how have we done? We have licensed 11 drugs since I started for pediatrics and women. And these include dispersible tablets, injectable long-acting medications, as well as some of our new areas. We have drugs now for tuberculosis that we've gotten licensed. And we are now working on hepatitis C during pregnancy drugs to get them licensed during pregnancy, and recognizing that syphilis is a major problem and that we are running out of the penicillin to use to treat pregnant women. We are actually now investigating other drugs, taking them off the shelf, developing long-acting modalities for those drugs to be able to treat those patients who have syphilis. So I think my time is up. I want to say thank you very much, and it's a pleasure seeing everybody today.
Any questions?
So, just to ask, so what is currently the state of the art for treating HIV, both adults and for children? What's most successful, and what are the outcomes with those treatments?
It depends if you're in the US or international. In the US, we now have long-acting antiretrovirals that can be given by injection every 2 months as fixed combinations, and those work incredibly well. We just got those drugs licensed for children 12 to 18, and the study for the 2 to 12s is almost finished enrolling. So the next steps will be using long-acting injectables. That's easy in the US. Are we there yet in sub-Saharan Africa? No. We are using fixed-dose combination medications for adults as well as children. But we want to move not only those long-acting injectables to sub-Saharan Africa, but we want to look at what else can be developed to a long-acting patch, an injectable, or even a long-acting oral, because taking a drug or 2 drugs every single day fatigues you out. But getting a shot once every 2 months or 3 months or even 6 months is going to be a win.
When the HIV treatments first came to market, did you see the same hesitancy and doubt of the scientific community that you saw when COVID happened and that vaccine came out?
Not at all, because our HIV-infected populations, if you remember, ACT UP was a very hot group then. HIV-infected patients died, and they died a horrible death in front of you. So the community was the exact opposite to what we saw during COVID. Not only did they want the meds, but even if something was half-assed and not great working at all, they still wanted to take the meds. And if you remember, at the start of the HIV epidemic, no two pharma companies talked to each other. You could have this drug from this company, this one, and this one. Treatment at that time was 3 different medicines twice a day. So you were taking handfuls of medicines multiple times. People were excited about getting those medicines because if they didn't take them, they were going to die. And that was quite different than what we saw with COVID. There was a lot of disbelief in COVID. No one really thought, oh, I'll get it, it's just a virus, I'll be fine, and ignore the mortality rates. And then there was this whole distrust of science through that social media echo chamber. Our echo chamber for HIV was fight them, get the drugs, give us those drugs. Very opposite for what we saw during COVID.
Just to go back to the beginning of HIV, at that time, I was in the nursing field and now I'm in the medical field, but we were not allowed to wear gloves. And it wasn't until HIV came into play that we were told, now we were allowed to. It was the human touch that we needed, our skin-to-skin interaction. So HIV brought that all on.
Right. If you remember, in Brooklyn, there was a case of a resident that got stuck from a needle. In those days, we didn't have all the safety guards that we have on needles, and the teaching was, oh, if you have a needle, just stick it in the bed, and then we'll just take it and throw it out, and nobody wore a glove or did anything like that. Yes, you're supposed to wash your hands. Okay, very nice. And unfortunately, there was a needle that was used for a big venipuncture on a patient that was on the bedside, and the resident went to touch the patient, got stuck with the needle, and acquired HIV, and then, of course, died. And there was a huge backlash on the across medical field, like, we can't let this happen anymore. And that's when everything changed, all the plastics, the fact that you could, with one hand, close a needle. You never recapped a needle. You never did anything. You held the needle, you capped it, and you discarded it. You never stuck it on the bed or kept anything like that. And that really changed medicine from what we have today. Our residents don't know that in the old days, you know, we never had the needles that we have now.
Even diabetic syringes were all metal. They were steel, they weren't plastic. There was a lot of, they were reused.
No one reuses anymore.
Mm-hmm.
Sharon, that was wonderful, thank you. So I wanted to ask you, what's your perspective on cure?
So interesting you should ask that, because I do have a slide, 2 slides forward. If you wait 1 second, let me get to it. So this is a study that we are in the middle of running. We've had version 1, version 2, version 3 is out there now. And it is early intensive therapy of infants who are infected perinatally, with the idea that if the kid is born on day 1, not in the US, we can test them for HIV. If they're positive, hit them with 3 drugs hard, or 4 drugs, or broadly neutralizing antibodies, in hopes of getting their viral reservoir down. And as part of getting their viral reservoir down, at some point, being able to stop their antiretrovirals. And when we set up this clinical trial, we had a big ethics group at NIH that was like, are you sure you can do this? Are you sure the families will approve it? Did you get a good consent? And we went through all the hoops, and yes, the study enrolled. And what we showed nicely, and this data was just presented at our big HIV meeting, is of the 7 children that met the criteria, all that, start meds, never have a viral blip, take your antiretrovirals 3-4 years later, let's stop your medicine and see what happens. 2 of those children rebounded right away. Clearly there was reservoirs that we couldn't account for. But 3 of the children did not rebound. And over 48 weeks later, stopping their meds, they stayed stopped. Fast forward a couple more months, One child now has rebound at about 70 some odd weeks after stopping the meds. The other two still have no virus. So the answer is, we do think you will be able to get, if not to cure, to a somewhat sterilizing cure, ART-free remission or antiretroviral-free remission in the near future. There's a lot of bells and whistles. And the fact that a pregnant postpartum woman who's breastfeeding has to give her baby 3 meds and herself take 2 meds is difficult. But with moving long-acting injectables into that space, so you don't have to take meds by mouth. Your baby doesn't have to take meds. We give you a couple of shots and the baby a shot. We can then go further ahead and we will get to more antiretroviral-free remission. So will it be cure? I don't want to call it cure, but it'll be a temporizing cure. And not taking medicine every day is still a win.
Let's give another round of applause.